Steve. There's Doc Jody. I don't want to talk about the Chiefs or the KU basketball because I know right now these two guys aren't going to like that. But first of all, Jode, we're going to talk about our medical topics. How's your Monday, buddy?
Hey, good Monday. Getting a lot done. And boy, a lot of news, a lot of medical news. And unfortunately, a lot of bad news from the war fronts, where many people are getting killed.
Yeah.
But what about the drowning in the hot tub?
Yeah, a lot of people are talking, and Steve, I'll get you to the loss of Matthew Perry. Toxicology's not out, but they pulled his body. Of course, he's one of the main Friends members, has had really an awful battle in addiction. No toxicology are out there, but I guess now all of the main conversations, Doc Steve and Doc Jody, is can somebody who's perfectly healthy die in a hot tub?
I think the answer to that is yes. And the reason is, your body temperature goes up. A lot of it depends on how long you stay in the hot tub and how hot you have it. And Steve, most of the time people like to go in, warm up, stay a little while, maybe talk to some friends in the hot tub. And boy, when it gets too hot, I want out of there. But I have friends and I know people who will take it to the limit. They'll just like, oh, I just want to be as hot as it can be, or go to the sauna and just get super hot. I can remember being in a sauna in Stockholm one time, and all these people, there were about 15 people in one sauna, and they were all groaning. They were so hot. They were just going, and they were just burning up, but they stayed there anyway. And of course, the crazy thing was that when you got out of there, you had to take a rope exit and go through an ice water tub, which really kind of confused you. But
was this for pain or was this for pleasure?
This was I was in there for pleasure, but by the time I got out, boy, I couldn't tell anything. But the interesting thing about this is that what happens when you are in a hot tub, or when you are too hot, hotter than normal, your temperature goes up, your pulse rate goes up, your blood pressure may go up or it may go down, but all of these things come into play. And if you have underlying heart disease, of course, that could be something that kill you. But Steve, even if you don't have underlying heart disease, it's conceivable that you could precipitate an arrhythmia by going into in a hot tub. That is very, very unusual. It's not a common cause of death. Would you say?
It's not a common cause of death, but I do have the history of arrhythmias, and I've walked into a room that was like a sauna, and the steam or a steam room. And once I took a breath, it threw me into a short run of VTAC, so I got turned around and got out of there. The most of the motel pools that I swim in that have an accompanying hot tub, they will have a list on the wall. And the two things I see in that list is, if you have heart disease, ask your physician before you get in.
Yeah.
Number two, don't stay longer than 20 minutes. Number three, no alcohol.
Yeah.
Now, I know people who break all those rules, especially the stay in longer than 20 minutes and the no alcohol, because that's one of the things that a lot of people like to do is get in a hot tub, get a glass of wine on the side, chill out for a while, and then warm up, of course. And certainly there's a risk in that. But I think in this case, what you have is a gentleman who has had a long history of drug abuse and all kinds of problems with that.
Yeah.
Now they're saying, well, there's no foul play here. I don't know how they know that yet, but they probably drew some blood, see if he had a high blood alcohol level or something.
Yeah, let me read a little bit more about this, because here's also what a couple of things. The U.S. Consumer Product warned almost 45 years ago that using hot tubs at water temperatures above normal body temperatures can cause drowsiness, which may lead to unconsciousness and drowning. That's one comment that came off. The other one I thought was interesting. Certain medications, they said in one article, can also increase the risk of drowning in general, especially medications commonly prescribed for depression, anxiety, bipolar disorder, because the side effects can be similar to the effects of alcohol. The CDC went on to talk about that. Hot tub water temperatures, this is what they say, CDC, should never exceed 104 degrees above Fahrenheit. I don't think anybody's out testing their water of their hot tubs in Hollywood, right?
Yeah, I don't know, but 104 is pretty warm. You know,
Yeah.
that's pretty hot. And so it's just a tragedy that it happened that way. And there are many possibilities for him. You know, he did have a history of drug addiction. He could be taking a drug prescribed to him, and you know that could be the cause of what happened here. Or he could have just had underlying heart disease and arrhythmias. And Steve, this could certainly be the cause of his death. You know, I doubt whether he got really intoxicated and just drowned with his face down in the water, but I guess that's also a possibility. But I don't think I ever knew that he had been hospitalized and rehabilitated 60 times in his life trying to get over drug addiction. Because when you saw him on television, he looked like the cool dude, didn't he? You know, he was funny, you know, he was nice to everybody, but they said just like 2 feet away, and he was a totally different guy.
Yeah.
So one of the things that happens here is that when you have a history of drug addiction, it's something that not only at the moment that you're exposed to any kind of stimulus like this, you may not be addicted, you may not have the drug on board right then, but just the history that you have may be enough to have changed your reactions throughout your body, your heart rate response, you know, the blood pressure response, all of these things that could cause this. But arrhythmias, Steve, that would be number one. If you have an arrhythmia, don't go in the hot tub. And if you do, don't stay over 10 minutes, and don't go in when it's over 100 degrees. What do you think?
I agree with that completely. That 100 degrees, that's not terrible. And most of the hot tubs have a little control strip, and it will tell you what the temperature is.
Yeah.
And so you can look at that, and it says 104. No, I'm not getting in there.
Yeah.
And 99, 100, I can get in there for just a tad. Uh,
Well,
you
I
know,
think,
the sleep doctors do tell you to take a warm bath before you go to sleep, and so
hmm,
they never put a temperature on the top of the warm bath.
Yeah,
So,
but not a 104-degree warm
but not
bath is the other,
104. You're
not
right.
104. But
well,
I'm the more I'm reading it is exactly what Dr. Galicia's talked about. If you have any kind of meds that are in your system for some time, heat can cause problems, especially if it's antidepressants, right, Jody?
oh yeah. And like I said, these saunas sometimes, you know, they're really nice for
Yeah.
just a few minutes. We have one, and you know, I like to go in there for a short time. But there are people who are visiting. Right now, I have a couple visitors, and these guys are telling me we spent 45 minutes in the hot tub and we turned up the heat, or in the sauna rather. And I'm like, oh my gosh, you know, to me, once you get once I'm in there a while and that temperature is way up, I'm ready to get out. But you know, everybody's different, and I think that you know, in some European countries, it's very common to be to have the temperature in a sauna set very, very high, and then do this ritual of going through the ice water plunge when you get out. And wow, you know, then you feel like a new person. Not me. When I did it, I tell you, it took a while to figure out what I was all about, period. I couldn't tell whether I was really awake or, you know, whether I was still alive, because that ice water drowning was just a tough one. But anyway, I'm sorry this happened, and I think it points out something really important, and that is that, you know, drug addiction, whether at the moment you're overdosing or sometime just in the future, because of your history of all of this, you are more susceptible to these things than many other individuals, Steve. And, a lot of times somebody like him is all on a bunch of other drugs, that somebody gave him to help control not only the addiction, but the depression and the anger and everything else that he has felt in his lifetime. So I really feel bad for him because of that history and the way his life has been distorted by that. But anyway,
Along
got to be
that
careful.
along that line, uh, at many of the 12-step programs, the people introduce themselves as their first name and then I'm an addict. The those that have been clean and sober are uh, not using for a long time still use that introduction
Yep.
because they understand that their ability for the drug to come back and get them is
Yeah.
really powerful, and they have to remind themselves every day that that could happen to them. So they have to be on their guard.
Yeah, no question about it. And it is a lifelong problem. Many of these people, I'll bet he's been cured 50 times, and walked out of there and said, I'm done with this. I'm not going to go there again. I don't know him, so I don't know his story, but many, many addicts that way, especially those with multiple admissions to rehab centers, they come to a point where they really understand how bad it is on their body, how dangerous it is for them. And when they leave, they're always saying, the first thing they say is, I'm done. I'm not going to do this again. And many of them, by the time they get home, they're doing it again. It's really a problem. And it has become a worldwide problem more than we would guess. I think I was telling you, Steve, once that in Saudi Arabia now, one of the biggest health problems they have is drug addiction. And you can't even buy alcohol in Saudi Arabia. But, when I ask the people there, what do you guys need the most? What kind of hospitals do you need? And they say, well, the thing we need the most are rehab hospitals because we're not used to this drug addiction problem. We don't have any. We need that badly because we need to learn about it and be able to help people. I was surprised at that, because they're so strict with everything. You can't drink alcohol, and people don't, they don't smoke much. They certainly don't have marijuana. So I don't know where they're getting the drugs or which drugs they're taking, but that's a problem. And of course, with fentanyl, we talk about it all the time, but fentanyl has now caused 120,000 deaths in this country this year. And that is really scary. So drugs just in general, no place for them, Steve, not in anybody's world. And you worry about your kids, you worry about people getting just somehow getting on drugs. And here's an interesting thing. It's been shown now that something like 70% of all people who are drug addicts started on drugs given to them by a doctor for pain. And what happens is that, you can't find a solution for the pain. So that the patient learns that in 1 week, they may understand that, hey, I can relieve myself of this severe pain by taking this medicine. And it's usually a narcotic. So there you go. What do? They go back and they ask for another dose. They'll say, give me another week and I'll be better. And then that short period of time, they can become addicted. It's pretty scary. The kids are becoming addicted in a different way. They're doing it through the contact with their peer group and that sort of thing. But scary stuff. Steve, you always hated to see somebody come on the drug and into the ER on drugs, or somebody that you had to take to surgery who was an addict, right?
Yes, you do. It's a concern. One of the things about this is years ago. I used to do really big operations through really big holes.
Yeah.
And I knew that the patient was going to have a really big pain. But by a week out, the pain may hurt a little bit when they move, but the pain that was caused by the surgery, it's minimal then. And we use lots of morphine and really strong drugs in the short recovery time. But the people that want it after they come back to see you for a well check in a month, those are the ones that you've got to be really careful about what you give
You
them.
bet. And here's another thing. Doctors want to please patients, right? You don't want them to suffer pain. So what's the easiest way for a lot of those patients? Is give them another script. And there are doctors that I know who have gotten in major, major trouble by doing this. They'll say, here's what, I know this drug helps relieve your pain. I haven't found another way to treat your pain. So I'm gonna write you a month's worth of scripts for the medicine, and then you can come in and pick them up at my office. My nurse will give them to you. That is against all rules. It's against all laws now for physicians to do that. In the old days, that was done. They'd say, well, I'll drop it off at the desk for you, or something like that. Now you have to, in person, give that patient a script for a pain medication like this.
You
And
know,
rules have gotten stronger, but the death rate for opioid addiction has gone up, and largely because fentanyl will kill you with one pink little pill. And that is scary.
one of the side effects of what you were just talking about with doctors and patients, doctors, hospitals really want to get good reviews. And I
Yeah,
don't know who the reviewers are, but you'll see in many hospital rooms a little chart, and it'll have a happy face with a one at the top, and then it'll have a round yellow happy face with a really bad look at
you
the
do that
bottom
well.
with a 10. And the patients are asked to grade the hospital and their care by those levels. And if you got a bunch
Yeah.
of those really bad levels, even though you're trying to help the patient not get addicted to pain, you get a bad report card on your hospital.
Yeah, I think a lot of doctors feel they're in a no-win situation here. And if you send a patient to a pain specialist, it's going to take a while sometimes for them to even get an appointment, because they're busy, busy people. And so then you got this interlude where they're having pain. You feel like you've given them the maximum amount of pain medicine that you're going to possibly give them. And so the patient is suffering during this time. And, a lot of times what they'll do then is they'll go to a walk-in clinic or someplace, and ask for more pain medicine. The doctor will say, well, what did you take? What was it that made you feel better? And then they'll say, well, it was this pill, and that was a narcotic. And so the temptation is to say, okay, let's try that for like 3 days, 4 days, do it 2 or 3 times, and there you go. Now you have addiction as a problem. Boy, it's something that is a worldwide problem. And to me, in surprising places, because I used to think it was kind of a problem of the US, but it is not. And there are places where it's easier to get drugs than here by far. A lot of places in Europe, a lot of places in the Far East, you can just go in and tell somebody you want that and you'll get it. Let's talk about a couple of other things. Now, Sal was trying to get on, and I don't know,
He's
did he
he's
make
just a
it?
couple minutes away. He just got done with
Oh,
a
he did.
procedure,
Okay.
Jody, so give him about
Because
3 more minutes, yeah.
yeah, he had some things he wanted to talk about, but I wanted to talk for a moment about Hashimoto's disease.
Okay.
There's an actress who was complaining of the following symptoms: tiredness, trouble sleeping, fatigue on just minimal exertion, weight gain, some symptoms that were disturbing to her. And she had just had a baby a few months before that. And so she thought this ought to be the healthiest time of my life. There was hair loss involved. Her focus, or her ability to focus on things, wasn't as sharp as it was in the past. Her ability to think clearly wasn't just right. So she finally went to the doctor, and he said, well, you've got Hashimoto's disease. And she's like, oh my God, what is that? And Hashimoto's disease is an autoimmune disease where your own body attacks your thyroid gland. So you wind up with hypothyroidism. And Steve, we've talked about that before. Hypothyroidism is not a pleasant thing, and it's when your thyroid gland, which controls the speed of your heart rate and the metabolic rate of your body, when it's not working, things don't work well, right?
You are correct. The things that I was going to talk about with Hashimoto's disease is exactly all the things that you enumerated already. As a surgeon, I would operate on patients that had thyroid cancers, and so I'd take the thyroid out, and that would make them very hypothyroid. So
Yeah.
we always treated that with replacement, and there are laboratory tests that check something called the TSH, thyroid stimulating hormone, and you can judge how much thyroid replacement to give these people. And the same with the people that have Hashimoto's disease.
Hey, Sal just joined us. Sal, we
Hey,
were having a little discussion here about a woman who described feeling tired, fatigued, all this constipation, all the symptoms of hypothyroidism, which occurred about 3 months after she had a baby. And it turns out that when they checked her, she had autoimmune disease, Hashimoto's disease, and they treated that, and then they treated her hypothyroidism by replacement. But this disease is not terribly uncommon, but boy, can it wreak havoc on the human body. Um, it's a disease you probably see rarely, Sal, or occasionally.
No, we see it. We see it. I wouldn't say rarely, but not very often. But we do see it. The I could talk to you about the cardiac manifestations of what hypothyroidism would cause. It's a general fatigue. Um, it could cause a slow heart rate
Yep.
um, um, from hypothyroidism, low thyroid levels. You could cause a pericardial effusion and cause the heart to not pump as well. Um, and overall, it could cause even to get really low where your whole body just swells up. So there's quite a few cardiac manifestations of hypothyroidism. That's sometimes when people come in, I do a workup looking for possibly thyroid disorder. One of the more common antiarrhythmic drugs that we use, amiodarone, is known to cause hypothyroid or hyperthyroid, either high levels or low levels of thyroid hormone. So that's one of the things we usually watch out for, and it's one of
Well,
our
if,
most
if
common antiarrhythmic drugs.
if somebody comes in the door and has a slow rate, a real slow rate, it's got to be on your list, especially if they're young and healthy otherwise.
Right.
Uh, could this be hypothyroidism? But, it's something you can treat. The Hashimoto's disease, you have to treat in a different way, really. You replace the thyroid hormone, but you try to treat the autoimmune disorder as well. Now, Sal, gosh, it's so good to see you. I
Thank
know
you.
you always have to hustle to get on this show with us. What are the things you want to talk about today? Anything on your mind?
Again, I was, just I'm getting ready to do a conference on obesity. I have to I have to look in the mirror and say, call the kettle black, as they say. I'm down this morning. I was 207 pounds.
you're
Uh,
looking good, Sal. I'm
down
telling, I can
from
see it right here in
down,
your
down,
face.
down from 275. And it was an embarrassment to the cardiologist and tell people they had to lose weight. And here
Right.
you are yourself. And so I've had a whole plethora of questions asked to me. How did you do it? What do you recommend? To the point where the two major conferences, the one last year that Dr. Galisha gave, helped me out with last year. I'm going to talk about obesity and the cardiac manifestations on obesity, as well as the whole system of a plethora of things, problems that occur with obesity. And I'm sure Stephen can talk about his issues from a surgeon's point of view and operating on people that are obese. So we're going to do the whole gamut. How to lose weight medically, how to lose weight, the surgical options, how to change your diet, the available diets. That's what I'm getting ready to do the next major talks on.
Yeah. Well, Steve, we've all seen hyperthyroid or hypertension, heart disease, hy- hypercholesterolemia. The list goes on and on when the weight is way, way up there. A lot of disorders of fractures and trouble walking, arthritis. The list is huge. But surgeons have to deal with obesity in our country every day, right? I mean, you walk in a room and somebody weighs 300 pounds and they're 5'2", and you go, oh boy, I'm in for a little bit of work here. And also a little bit of an increase in risk too, right?
Yes, it's significant increase in risk, and particularly if you got the patient intubated for a long period of time, paralyzed, and then you've got to get him awake and moving. That's the biggest problem with operating on anyone after surgery is moving. And if you got to move 300 pounds as opposed to 125 pounds,
Yeah.
that's a really, really hard problem. But one of the things, this is just a aside, but I can't help bringing this up. When I was a surgical resident, we would rotate through the Cincinnati Children's Hospital. And we do some of the operations there that we did on adults over at the university hospital. And those pediatric surgeons, they look so smooth. They were so smooth. Their technique was wonderful. And as I've gotten older, I realized, oh, they were operating on people with no fat in there. There was no fat in the way, and
Not yet.
that made the operation go so much simpler.
Sal, here's a question for you. What do you think about the anti-obesity drugs? They seem to be very effective, and there are new ones on the horizon. There are a
Right.
couple that are out there now. People are using them. Do you see anything bad happening with these drugs?
So
But
far, not.
you,
I'm not. I'll be freely admitted. I took a three kind of like edged approach to the problem I had. One was I had to first tell myself that if I was being obese at 65 years of age, my chances of living into my 90s was very small, and I knew that what comes with that problem was going to be a lot of orthopedic problems and back problems and things like that, and probably it just spirals down on you. The heavier you get, the worse it gets. So I knew. I decided I had to obviously change my diet. I mean, I had to change the way I eat. Like today, somebody brought, brought Panera bread here, bagels and everything like that. And I used to eat that stuff all the time. No, not going to eat that stuff. Not that you can't have one every once in a while, but it just can't make it part of your daily, everyday type of thing. So I had to change my diet, and I think I talked about I've kind of gone towards the DASH eating plan, DASH, diet against systolic hypertension plan. I watched what he said. To help me with that, on my iPhone, I have a thing called MyFitnessPal, and it basically records of everything I eat, from calories. I set a goal. Now, for me, I set the goal a little bit lower. I set it at 1,400. There's a way you can calculate on your activity what your goal should be. For most men, 6 foot, and above, somewhat active, it's probably about 1,800 calories and above, right about that per day. I set mine at 1,400. But then I also figured I had to exercise. I had to do something. So I started walking every day, just simply walking. Then like this morning I did 5 miles. It took me a while. It
whoa,
took me about 80 minutes to do it. But I
oh, wow.
ran a little bit. I would run here and sporadically between, every once in a while, try to increase the pace, increase the incline, try to make it get a little better. So I was exercising at least 5 times a week. So changed my diet. I did change the way I looked at things. I counted. I got help from a plan, watching what I was eating calorie wise, keeping track of that stuff.
What
And the
about
last thing
drugs, though?
I did take one of the newer drugs. I took
Yeah,
Ozempic,
yeah.
which people have asked me, well, does that really work? What are the side effects? We do not know the long-term side effects. We don't know years from now they're going to come. It's associated with this cancer, associated with that. We don't know.
What was the brand again, Sal? What was the brand?
Ozempic.
Oh,
There's
Ozempic.
one of the newer drugs out there. The other big company out there is Mounjaro, is the other major one. And there's actually a oral. Those two are injectables. You take injectable once weekly. The way they work is, you've seen the commercials on TV. They have proven to be, one, lower your hemoglobin A1C. Both of them have shown that. The other is, both of them have shown to reduce your long-term cardiovascular effects. That's the one I'm after as a cardiologist. And thirdly, as one of its side effects, it apparently you kind of get fuller quicker, so you don't eat as you feel. You have an early satiety response to the drug. So instead of eating a lot, you get fuller quicker. And the mechanism of action, I don't believe, is really known. They postulated on a couple mechanisms. So I've taken that. The problem with the medicine is it's very expensive. If you're not diabetic, it's going to cost you about $800 a month for the medicine. So it hasn't been approved by the major insurance carriers for diet use. It's been approved for diabetes only if you fail the standard diabetic drugs to control your hemoglobin A1C.
Yeah, you gotta fail the insulin and all the other things before you can take it.
Metformin being the big one. The big one, and some of the other newer ones, but it works. And so, but it's like I said. Then I asked the representatives of the two companies. I said, "Okay, what happens when you stop taking the drug?"
Yeah, that's a question.
What's the thing? And they said, "Well, we've noticed that for those people that have not changed their diets, have not exercised, they will gain the weight back probably." He says, on the other hand, if you've changed your diet, really gone to a diet plan, started exercising, you will more than likely keep the weight off. And so there's a list. I think Brett's showing us a list of the common popular weight loss drugs. There's some other ones out there that some of the diet drugs use, phentermine pills for weight loss and things like that. So this is the one I tried. So again, we'll see how it goes. Hopefully, like I said, I've made a commitment to a good diet. I mean, we all like to be like Dr. Galicia, right, Steve? He's at his age, he's still out there playing tennis. He's still moving. Jesse James Leha was a good friend of mine, the famous boxer. I saw him the other night, and I was telling him how I was started to hit the ball a little farther, getting around. He goes, well, he told me, he said, Sal, he says, he said, a body, my number one expression to all the people that I train, a body in motion stays in motion, a body at rest stays at rest. And he says you have to not only do your cardio, but you have to work on your core. Mm-hmm. And that's a whole nother discussion. So I started working on my core so I can gain a little bit more speed through the golf ball.
A lot of people don't know what the core is. Actually.
Right. So we have to talk about that someday. But
we can have a whole discussion.
Let's get Jesse James on here.
That'd be fun.
Let's get him on the show.
Yeah, let's do it.
Let's do it and see. He's like the ultimate. Who better than a boxer to tell us about training? But he trains a lot of the Spurs athletes, and he's a very nice guy, and he was a great boxer, great athlete. And
I think one of the biggest questions people are having right now with these drugs, and I think the weight loss drugs are effective. I really do. And there are 4 or 5 of them on the horizon that look like they're going to be cheaper and maybe more effective with fewer side effects. But the ones that we're using right now are expensive. So the question is, how long do you take it? You get your weight down. What if you just stay on a lesser dose? Those are questions that people ask. Do I want to be on Ozempic for the rest of my life and spend $800 a month? Well, that's a big question. So I think some of these drugs will get cheaper. I think there are newer ones out there, going to be easier to take. And we'll keep our eye on this, Sal, because look what it's done for you. I mean, You look great. And
thank you so much.
I know you're approaching your 60s, and
65. Thank you.
Yeah, right.
What's the Achilles heel, Sal? What's the food that's your Achilles heel that you've battled a lot? Is it the bread?
I'm Italian. It's bread. It's pizza,
it's bread.
Anything bread. So again, if you're going to have bread, it's not, you can have bread, but I've gone to more of the whole wheat, a little bit, and gone to the gluten-free type stuff, and working on that. And the other option,
Not
Oh,
easy.
we lost him. Doggone it. That
Hey,
happens sometimes when he's at the hospital Wi-Fi.
yeah.
Steve, what is your Achilles heel? Is it the ice cream at the DQ down the road?
Oh, that is, but I've been able to stay away from that one. The real problem that I have now is being social. This last Saturday, the Lions Club had turkey and noodles.
Mm.
The Knights of Columbus had biscuits and gravy.
Oh, yep.
And then in the spring, with my Kiwanis Club, we have these wonderful pancakes.
Yeah.
Participating in all of those types of events, I give myself permission to do it, and I really shouldn't.
Yeah, it's hard for me too. I like
It's
ice cream,
it's always for a
but
good cause. It's always
yeah,
for a
yeah.
good cause. All right, guys. Hey,
Hey,
thanks.
thank
Appreciate
you.
it. You guys did a great job today. Please, if you have any questions for the docs, fire off on the show. We'll get to that next time.
Hey, thanks.